Let's make a table regarding the other types of shocks now. So we've already discussed hypovolemic shock. Hypovolemic we've already discussed. The other type of shocks can be cardiogenic shock. So this is related to cardiac causes. Then another very important one is neurogenic shock. This has also been asked in the exam quite frequently. You have anaphylactic shock. Anaphylactic shock, and you have septic shock. Septic shock, you know, is divided into a warm septic shock and a cold septic shock. Two more terms which you need to know. You can have obstructive shock. This I'll cover in some time. You can have distributive shock. After making this table, I'll cover these two terms. And the third one is endocrine shock. Right, so these are three more types of shocks. I'll tell you about them once I've made this table regarding these 5 types. And the various parameters which we need to consider in this table are pulse rate, cardiac output, systolic blood pressure, JVP. JVP is jugular venous pressure, and peripheral vascular resistance. So first let's write peripheral vascular resistance and JVP. PVR is peripheral vascular resistance, JVP is jugular venous pressure or the CVP, central venous pressure. Now hypovolemic shock we've already covered, and we are assuming that we have a patient in class 3 hypovolemic shock. We are assuming a patient in class 3 hypovolemic shock. Let's fill in the blanks. We know that there is going to be tachycardia, and class 3 hypovolemic shock, the cardiac output is going to fall. Cardiac output falls, and we know that systolic blood pressure also falls for the first time in class 3 shock. Peripheral vascular resistance. Now we've discussed that the extremities are going to be cold, right? And whenever we have cold extremities, why do we have cold extremities? Because there is peripheral vasoconstriction. And when there is peripheral vasoconstriction, what will happen to the resistance? It is going to go up. So the peripheral vascular resistance is going to be raised. Please don't get confused. Yes, initially peripheral vascular resistance rise is going to give rise to increase in diastolic blood pressure. But as the blood volume loses from the body, as the blood volume is lost from the body, then the diastolic blood pressure is also going to fall. Okay. JVP also falls because there's loss of circulating blood volume. So these are the parameters for hypovolemic shock. Cardiogenic shock, there can be multiple causes of cardiogenic shock. You can have myocardial infarction, you can have arrhythmias, you can have tamponade. There can be various causes of cardiogenic shock. We can consider anyone. Let's consider a patient who's had a myocardial infarction. So when there is a myocardial infarction, the cardiac output is reduced. The heart is not working properly. Because the cardiac output is reduced, the systolic blood pressure is reduced. And because the cardiac output is reduced, blood is not flowing to the extremities properly. So the extremities are cold. Extremities are cold. There is vasoconstriction in the extremities. So because there is vasoconstriction, there is increase in peripheral vascular resistance which is there. And also you need to remember that because the heart is not working, the cardiac output is low, the preload is the blood which is there, which the heart has to pump out, right? So the preload is accumulating, and this leads to increase in JVP, and you have engorged and dilated neck veins. Okay. So this is regarding cardiogenic shock. If we have to fill in the table now, pulse rate can either be increased or decreased. Why? Because in arrhythmias you might have a high heart rate, whereas if there is a patient who has a heart block, which can also give rise to cardiogenic shock, there will be bradycardia. So you can either have increase or decrease in pulse rate. Cardiac output is going to reduce, systolic BP is going to reduce, extremities are again cold, so peripheral vascular resistance increases, and because the heart is not pumping out blood, there is raised JVP, engorged neck veins. Moving on to very important neurogenic shock. Neurogenic shock has been asked almost the same number of times as hypovolemic shock. Now, neurogenic shock, we are going to consider the example of a transected spinal cord, after a road traffic accident. In the trauma module, I've told you that cervical spine is very important for us. If there is a cervical spine injury, that can give rise to spinal shock. There can be transection of the spinal cord and it can give rise to neurogenic shock in patients. Okay. So here I just want you to remember one thing. If you just remember this one term, the entire physiology would become very easy for you to understand. And that one term is that when the spinal cord is transected, there is loss of sympathetic tone. There is loss of sympathetic tone. Just this one term is enough to understand the physiology. When there's loss of the sympathetic system or loss of sympathetic tone, you know what is going to happen. There is going to be vasodilation is going to be there, right? We are going to have vasodilation. And these patients are also going to have bradycardia because there is loss of sympathetic tone. So there is going to be bradycardia. That means the heart rate is low and there is vasodilation in the periphery because the sympathetic tone has gone. Now, when there is peripheral vasodilation, extremities are going to be warm because there is more blood accumulating there. So you have vasodilation, warm extremities, and this is going to give rise to pooling of blood. Why is there pooling of blood? Because our poor patient is lying on the ground after the accident. His spinal cord is transected, cannot move, and all the blood is there in the peripheries, but the blood is not returning back. Right? Blood is not returning back. So there is pooling of blood. There is decreased venous return. Now, if there is decreased venous return, common sense question, what is going to happen to the preload? The preload is going to reduce. So decreased JVP because less blood is returning. Decreased JVP, decreased preload means decreased cardiac output, which means decreased systolic blood pressure. So this is the physiology behind neurogenic shock, right? Let's fill in the blanks now in the table. So neurogenic shock, you can see there is bradycardia occurring. Cardiac output is also reducing. Systolic BP is also reducing. Peripheral vascular resistance is reducing. Why? Because the extremities are warm. And JVP is also falling because the return is less. So all the parameters have reduced. And the question which has been asked umpteen number of times is bradycardia and hypotension are seen in which shock? They are seen in neurogenic shock. They are seen in neurogenic shock. Please don't confuse this with bradycardia and hypertension, which is seen in head injury. Bradycardia, hypertension in head injury is Cushing reflex. I've covered that in the head injury module, right? Don't confuse that with neurogenic shock. Neurogenic shock is brady and hypotension. Okay. Let's talk about anaphylactic shock now. Anaphylactic shock, we are going to consider the example of a mismatched blood transfusion. Right, so anaphylaxis, you can have mismatched blood transfusion. Now, when there is a mismatched blood transfusion, histamine is released, and histamine is the driver for this anaphylaxis and anaphylactic shock. You know, large quantities of histamine are released. Now I want you to very carefully observe what is happening in this shock, okay? And this is the correlation which I want you to understand. So when histamine is released, you know histamine is a potent vasodilator, right? Potent vasodilator. So look carefully. Vasodilation. This is going to give rise to warm extremities. This will again give rise to pooling of blood. Again give rise to decreased venous return. Again give rise to decreased JVP. Again decreased cardiac output, decreased systolic blood pressure. So the story is exactly the same as neurogenic shock. But what is the difference here? But sympathetic system is normal. Sympathetic system is normal. Therefore, pulse rate is going to increase. So everything is the same as neurogenic. The only difference is that there is going to be tachycardia in anaphylactic shock. Rest is the same as neurogenic. So easy to remember. Anaphylactic shock, tachycardia, rest everything reduces as neurogenic shock. Okay. Moving on to septic shock. Septic shock, you have two phases of septic shock. So in the warm phase of septic shock, I just want you to remember one term. The term which I want you to remember in warm septic shock is hyperdynamic circulation. Is hyperdynamic circulation. That is the only term which I want you to remember in warm septic shock. So what is happening? The heart is working quickly. When you have fever, there is tachycardia. Heart is working quickly. Blood is quickly going through the body and coming back, right? So blood goes quickly, comes back quickly. There is a hyperdynamic circulation which is there. So there's going to be tachycardia. There's going to be tachycardia because the heart is working overtime. There is cardiac output is going to be increased. So when the cardiac output is increased, systolic blood pressure will also be increased or normal, right? Extremities are warm. It's there in the shock itself, warm extremities. So warm extremities means peripheral vascular resistance is low. Extremities are warm. And what is happening to the JVP? So understand this. This is very important. Whatever the heart is pumping out, it is coming back, and again the heart is pumping that out, right? So pump, comes back, pumps, comes back, it pumps again. There is no backlog which is occurring here, right? No backlog of preload. So JVP is normal. JVP is normal in these patients. Okay. This is warm septic shock. Cold septic shock, I want you to remember that in late phases of sepsis, what happens? Bacterial toxins inhibit the myocardium. The bacterial toxins inhibit the myocardium. Therefore, late septic shock or cold septic shock is equal to cardiogenic shock. So the parameters of cold septic shock are exactly the same as cardiogenic shock. So this is another easy correlation for you so that you can remember this for the exam. Right. Now these three terms which I mentioned, obstructive, distributive and endocrine shock, what exactly do these mean? First, let's talk about obstructive shock. So obstructive shock by definition is a shock in which the preload. So obstructive shock by definition is a shock in which the preload is reduced due to mechanical impairment in cardiac filling. Due to mechanical impairment in cardiac filling. Right, so what exactly does this term mean? Let's consider the examples of obstructive shock. You can have cardiac tamponade. Cardiac tamponade I've covered in the thoracic trauma module. Cardiac tamponade, you know that there is rapid accumulation of blood around the heart. Rapid accumulation of blood around the heart. And because of this, the heart cannot relax. If the heart cannot dilate or relax, filling will not happen. Right? And if filling does not happen, cardiac output will not get generated. Okay? So this is one example, cardiac tamponade. Another one is a massive pulmonary embolism. A massive pulmonary embolism is also going to hamper cardiac filling. And when cardiac filling gets hampered, the cardiac output and the systolic blood pressure reduce. So this is obstructive shock. Distributive shock. So distributive shock is when the blood redistributes to the peripheries. When the blood redistributes to peripheries, thereby reducing cardiac output. Right? So when there is more blood which accumulates in the peripheries, less blood is coming back to the heart, and that is going to give rise to shock. So what are the examples of distributive shock? They are going to be neurogenic, you will have anaphylactic, and you will have warm septic shock. So all the three shocks in which the extremities are warm, they classify as distributive shock. So easy way to remember, any shock with warm extremities is an example of distributive shock. And endocrine shock. Endocrine shock can be a combination of distributive and hypovolemic and cardiogenic shock. Right? It can be a combination of these shocks, and endocrine shock you can get in hyperthyroidism, and adrenal problems, and in patients with adrenal problems. Okay, so these are three more definitions which you should know, and this covers the various types of shocks which you need to know for the exam. Now we are going to talk about septic shock in detail, because that is a very important topic for the exam. So we'll talk about sepsis. So there are certain definitions in sepsis and septic shock which are asked frequently in the exam. The first one which you need to know is SIRS. SIRS stands for Systemic Inflammatory Response Syndrome. It is Systemic Inflammatory Response Syndrome. In simple terms, what is this? In simple terms, this is the body's response. This is the body's response to inflammation. It is the body's response to inflammation. Now this inflammation can either be infective or non-infective. So it can be secondary to infection, or it can even be secondary to trauma. So it's not necessarily that it's all because of infection or sepsis only. This is mediated by IL-1, IL-6 and TNF-alpha. mediated by IL-1, IL-6 and TNF-alpha. These interleukins have been asked in the exam, which control the SIRS response of the body. What are the parameters? The parameters are temperature less than 36 degrees centigrade or more than 38 degrees centigrade, WBC count less than 4,000 or more than 12,000, or more than 10% band forms in peripheral smear. This last one is something which students forget. So please make sure you don't forget this. This has been asked in the UPSC exam many times. Third parameter is respiratory rate more than 20 per minute or PCO2 less than 32 millimeters of mercury, right? And the final parameter is pulse rate more than 90 per minute. So these are the 4 parameters which you need to remember regarding SIRS. So these are the 4 parameters which you need to remember regarding SIRS, and if any 2 parameters are met, then we say that the patient is having SIRS, systemic inflammatory response syndrome. What are the other definitions? The other definitions are sepsis. So sepsis is SIRS plus a known site or known foci of infection. Means supposing if somebody has a boil and that boil is giving rise to SIRS, then we will say that the patient has sepsis, because the patient has parameters of SIRS, but the cause is that boil. So we are going to say that the patient is in sepsis. Septic shock. Septic shock is sepsis plus hypotension. Sepsis plus hypotension which fails to respond to fluids. That is septic shock. MODS, multiple organ dysfunction syndrome. Multiple organ dysfunction syndrome. So MODS is when there is failure of two or more organ systems. That is when we say the patient has MODS. This has a high mortality rate. Now, one thing which I want you to understand is that kidneys will be one organ system. It's not as if one or both kidneys have failed, so you won't count it as 2 organs. So kidneys would be one organ system, respiratory system would be another organ system, cardiac would be another organ system, CNS would be another organ system, right? So if there's failure of 2 or more organ systems, we label it as MODS. So these are certain definitions which you need to remember. Now there has been certain new updates regarding sepsis, and those updates I want you to know. The first update is the SOFA score. This is the sepsis related organ failure assessment score. This is the SOFA score. And if you have a SOFA score of 2 or more than 2, plus known foci, then we call it sepsis, right? A SOFA score of 2 or more than 2 plus a known foci of infection would classify as sepsis. But what you need to understand here is that this SOFA score is such an elaborate score that it becomes difficult for us to measure each and every parameter. So to circumvent that problem of having so many parameters, they've also come out with a QSOFA score. What is QSOFA? This is quick sequential This is quick sequential organ failure assessment score. Quick sequential organ failure assessment score is QSOFA. And what are the parameters which are included in QSOFA? You have systolic BP less than 100, altered mental status, and tachypnea more than 22. Please don't get confused. Here tachypnea is more than 22, but in SIRS tachypnea guideline was more than 20. So they're different. Don't get confused between the two. Now, if you have a score of 2 or more than 2, it indicates a poor outcome. So you need to remember QSOFA, you need to remember the parameters. In the last 4 years, there have been 6 questions in various exams regarding QSOFA. This is very, very important for your exam. So sepsis 3.0, these are the latest guidelines. What are the updates which we need to remember? The definition of sepsis now has changed. One definition I've told you is SOFA score of 2 or more than 2 plus known foci of infection. Another one is life-threatening organ dysfunction caused by a dysregulated host response to infection, right? So that is another definition of sepsis. Septic shock, the definition has changed, very important. It is the need for vasopressors and a serum lactate more than 2 millimoles per liter. And a serum lactate of more than 2 millimoles per liter. The term severe sepsis has been removed and SIRS is out and QSOFA and SOFA are used. One more thing, this is not there in Bailey, but it's there in Sebastian, the surviving sepsis guidelines. And you had a question in the NEET exam last year from the surviving sepsis guidelines. Now, these guidelines say that within the first 6 hours of resuscitation of a septic patient, we need to achieve all these goals. What are the goals which we need to achieve in a patient with sepsis who's undergoing resuscitation? We need to get a CVP of 8 to 12 millimeters of mercury, MAP, mean arterial pressure, of more than equal to 65 millimeters of mercury, urine output of more than equal to 0.5 ml per kg per hour, and MVOS, mixed venous oxygen saturation, of 65 or more. I told you some time back that MVOS in sepsis is increased and we have to maintain it that way so that adequate oxygen reaches the tissues. So the MVOS in sepsis should be kept between 65 to 70. Okay. Also, we need to normalize lactate in these patients. Now, if you have a patient with septic shock, first give fluids. We have to first give fluids, and if they are not sufficient, then we can start the patient on inotropes and vasopressors. Like you can start the patient on dopamine, dobutamine, noradrenaline, but all of these are started only once the patient has failed on fluid resuscitation. Okay. So this is the management of septic shock. I've told you the definitions which are important for the exam, and this brings us to the end of this module. I've told you time and again that this module is very, very, very important from the point of view of all exams. Before we end, let's just solve few MCQs. So which one of the following is seen in massive blood transfusion? Now, I've told you that both metabolic alkalosis and acidosis can be seen, but what is more important and more common is metabolic acidosis. So if you're given a question like this, you will choose metabolic acidosis. The capillary refill time is prolonged in all types of shock except, right? So capillary refill time prolonged. When will capillary refill time be prolonged? When there is vasoconstriction and less blood is flowing, or when there is vasodilation and more blood is flowing? Of course, when less blood is flowing, that is when capillary refill is going to be delayed, so, or prolonged. So that is going to happen in hypovolemic shock. It is going to happen in cardiogenic shock. Obstructive shock, you know, is a type of cardiogenic shock only. So here you will have cold extremities, cold extremities, cold extremities. So the capillary refill time will be prolonged. Septic shock, you know, you have warm extremities. So here the capillary refill time will not be prolonged. Okay, this is another practical application of that table which we have discussed. You have a 26-year-old man with road traffic accident. He had a pelvic fracture and was transfused blood. Within a few hours, the patient develops fever, oliguria and hypotension. CVP is normal, but there is bleeding from the site of the IV line through the Ryle's tube. What is the most common diagnosis? This was asked in the AIIMS exam. Fat embolism, you know, can occur after a long bone fracture, but it occurs after around 24 to 48 hours. So this is out. Adrenal insufficiency, there is no indication that this patient might have adrenal insufficiency. Hemorrhagic shock. If there was hemorrhagic shock, CVP, how will CVP be normal? For CVP to be normal, cannot be hemorrhagic shock. In hemorrhagic shock, CVP or JVP will be reduced. We've discussed this. So this is also out. So even by elimination, we can reach to blood transfusion reaction. But the classic keyword here, which is a throwaway that it is a blood transfusion reaction, is that there is bleeding which is happening from the IV lines, from the Ryle's tube. So there is coagulopathy which has started happening. And you can see this is a direct picture from Bailey, where if antibodies are present in incompatible transfusion, this is going to result in acute hemolytic reaction. So hemolysis is what is happening there, and that is what is giving rise to the transfusion reaction in this patient, which is not a complication of massive blood transfusion. So we know hyperkalemia can occur, we know hypocalcemia can occur, we know hypokalemia can occur. So hypercalcemia will not occur. Okay, this was another question asked in the exam. Right, in hemorrhage, larger arterioles vasoconstrict in response to the sympathetic nervous system. Yes, that is why there are cold extremities when there is hemorrhage. Which categories are associated with vasodilation of large arterioles? So don't get confused by such technical questions and technical terms. Try to simplify it for yourself. Okay. The examiner is saying that in hemorrhagic shock, there is vasoconstriction. So the extremities are cold. Now he is asking which are the shocks where there is vasodilation. So if there will be vasodilation, extremities are going to be what? Extremities are going to be warm. So which are the shocks where extremities are warm? You have septic shock, neurogenic shock. So the answer becomes A and C. Following a recent abdominal surgery, the patient is in the ICU with sepsis. Below what level of hemoglobin would a transfusion be indicated? I've told you that transfusion now is indicated when it is 6 or close to 6, that's when we are going to do transfusion. If it's 6 to 8, then there has to be ongoing losses, then only we transfuse. Okay, so this is a very important question. This is where you're given a clinical scenario and these are the options which you have to choose from. Whether the patient has SIRS, sepsis, MODS, septic shock or severe sepsis. So let's look at the statements and see what the patient has. You have a 44-year-old male. He has an ileal perforation. On the third postoperative day, he has pain and an ultrasound reveals that there has been a leak. So there is a leak after surgery, there has been a leak. His pulse rate is 100 per minute, tachycardia, BP is 100 by 80, WBC count is 15,000, respiratory rate is 20 per minute. The urea is 70, creatinine is 1.5. He is conscious and oriented but complaining of pain. So what does this patient have? Okay, let's start step by step. Like I told you the definitions. Does this patient have SIRS? Yes or no? Let's see. His counts are raised and his respiratory rate is more than 20. So two parameters are met. Yes, he has SIRS. Now, does he have a foci of infection? That is the next question I need to ask myself when I'm approaching such questions. Yes, he does have a foci of infection. There is an ileal perforation leak which has occurred. After repair, there has been a leak. So, I know that SIRS plus foci is equal to sepsis. So, this much I know that this patient is having sepsis. Does he have MODS? Does he have MODS? You know, MODS is failure of two or more organ systems. So, if you look here, his kidneys, urea is 70, kidney function is deranged, kidneys are gone. So, one organ system is gone, but he is conscious and oriented. So, CNS is intact. So, only one organ system is affected here. So, does he have MODS? No, he does not. So, what is the answer here? The patient has sepsis. I hope this is clear because you can expect many more questions like this in your next exam, in your INI CET exam. You will be shown clinical vignettes like this and you'll be asked questions. And I've just told you the approach to such questions. Okay. Let's look at another patient. We'll follow the same approach. You have a 65-year-old diabetic patient who's been brought with Fournier's gangrene. Fournier's gangrene, you know, is necrotizing fasciitis of the perineal region. The pulse rate is 110. So, tachycardia, BP is 90 systolic. BP is also falling. On giving fluids, BP does not improve. Okay. He started on dopamine, noradrenaline and debridement is planned. His liver functions are marginally deranged but other blood parameters are normal. So, let's do the same analysis as we did here. Does this patient have SIRS? Yes. Why? Because there's tachycardia and there is hypotension. So, two parameters are met. Yes, he has SIRS. Does he have a known foci of infection? Yes, he has Fournier's gangrene. So, he has SIRS and he has Fournier's, so he has sepsis. This much also we know. Is there septic shock? Is there septic shock? Well, there is hypotension and it does not improve with fluids, does not improve with fluids. So, yes, there is septic shock in this patient. Is there MODS? No, there is no MODS because only his liver functions are deranged, rest of the parameters are normal. So, here the answer is going to be septic shock. So, you can see different clinical scenarios and how have we utilized the definitions which I told you to answer these clinical scenarios. This is very important for your future exams. This brings us to the end of this very important module on shock. Thank you.